Welcome to the Seniors Flourish podcast, where it's all about helping occupational therapy practitioners working with older adults be the best they can be. And now your host, Mandy Chamberlain.
Hi everyone. Before we get started, I wanted to talk about Seniors Flourish's sponsor, Great Seminars and Books. What I really like is that their mission is focusing on geriatric rehabilitation education and training for clinicians, which, as you know, is near and dear to my heart. They have great live courses focusing on topics such as clinical orthopedics, cancer rehab, or even topics such as clinical neurology. There is a course for anyone looking for evidence-based practice and treatment ideas while working with the older adult population. These are definitely some topics that I am interested in, and I think you should check them out too. So head on over to seniorrehabproject.com/great and use my promo code SRP25 to get $25 off your next course. Welcome everyone to the Seniors Flourish podcast. I'm your host, Mandy Chamberlain, occupational therapist. And on this podcast, we talk about everything geriatric and occupational therapy. Today, we have the topic of low vision. And I am joined by Cami Caldwell. She's an occupational therapist. And she loves low vision, don't you?
Oh my gosh, I love low vision. I definitely do.
So we're going to obsession. So we're going to be talking about low vision today, and she's going to give us some awesome tips and some things to be paying attention to with our patients. So welcome, Cami.
Thank you so much for having me, Mandy. I'm such a fan of yours, so I'm so excited to be here.
Oh, I'm really excited you're here too. I probably say this every episode, but I'm really excited I'm always like, I'm so excited you're here because I am excited you're here. I'm kind of like this excited podcaster host. So I'm excited you're here, Cami. So let's talk about your OT journey. And kind of like what you're currently doing in the OT world.
So I actually started, I've been an occupational therapist for 6 years. And I started in a large hospital setting in New York City. And I actually worked on a traumatic brain injury unit for the first 3 years of my practice. And it was such a great experience. I learned a ton there. Then my fiance and I moved to Washington, D.C. And I sort of shifted gears. I got a job at a skilled nursing facility. I really love the geriatric population. So I started full-time there, and then I kind of transitioned part-time there as well as home health. So that's sort of what I'm doing now. On weekends, I work at a hospital as well here, but I'm mostly doing home health and skilled nursing facility. And of course, I just recently graduated from the University of Alabama in Birmingham from Mary Warren's low vision program. So I have my graduate certificate in low vision.
Super cool.
Yeah.
I bet and it's so helpful for obviously our population, or the population you're working with. So how did you become interested in low vision? Why did you decide you wanted to do that or pursue the certification?
It's really funny. When I started at the hospital setting, I was a new grad, and, like I said, it was a lot of neuro because it was a traumatic brain injury unit. We did have an ortho unit as well. But I really shied away from vision because I found it to be quite challenging. As a new grad, it's a little bit tough to kind of tease out what is vision versus cognition versus maybe a physical impairment if there's a head and neck issue. So I hate to say this, but I really didn't like it.
Yeah.
Every time I would have to, they did something really, really good. They required us to screen for vision issues on every single client, no matter what they had, whether it was a neuro or an ortho or cardiac, whatever it was, every single client, you had to do a vision screen, which I'm really thankful for looking back.
Yeah, definitely.
I didn't mind doing the basic screening, but when it became a more complex issue, I just really shied away from it. I didn't feel confident enough to kind of treat it or assess it.
Mm-hmm.
But so when I moved to DC and I started working at the skilled nursing facility, I continued that kind of requirement of assessing every single person for vision impairment or just doing a quick vision screen.
Mm-hmm.
And I found over and over and over again that the clients in the nursing home were just a lot of them had vision impairment. So I actually created some low vision boxes.
Oh, yes.
Yeah, it was, I know. Cause we didn't have anything. We had no assessments at my last job. We had the BIVABA. I'll get into that later.
Mm-hmm.
It's a, pretty big visual assessment created by Mary Warren. And, we didn't have anything. So I was kind of starting from scratch. I'm like, we have nothing. So I was just kind of using, like, I would have clients sort of read from, newspaper or magazine and sort of assess their near vision that way, or not a standardized assessment, but just sort of observation kind of stuff.
Yeah.
And then I said, well, you know what? I'm going to take a class. I really need to learn more about this. So I knew about Mary Warren, and I knew she does classes. She travels around the United States and does classes. So I decided I'll just take one of her classes and just sort of see what I can, kind of bring to my sniff.
Yeah.
And, I kind of stumbled upon her program, and I applied and I got in, and it was a great experience. It's 5 semesters, and that's sort of how my journey has begun. That's
really cool because, I mean, I'm filling it sniffs. I've kind of worked a little bit of everything, but except for when I worked with a head injury unit, kind of similar, there's no place that required any kind of like really good assessment. So it's like the things like you asking your patient, right? Do you wear glasses? You have any trouble with your vision? Or
Exactly.
if they have like a stroke, you might do check for vision cuts or, that kind of thing. But like when you're working with the older adult, how many people have low vision or, low vision issues? So many.
Oh my gosh.
And typically you're not seeing them for low vision. At least I'm not in my general practice, right? Like you're seeing them for something else and you want to do a quick assessment, quick screen, but like most people have something. And I think a lot of us, I shouldn't say a lot of us, maybe that's just me. That's me, projecting.
I think a lot.
Yeah. Just projecting a bit, saying like, I know I don't do that thoroughly enough. So I'm super interested to hear some of your little tricks of the trade, that kind of thing.
Definitely. I mean, the big thing is, there aren't a lot of low vision occupational therapists out there. Mm-hmm. The ones that are out there, it's a great community. People are very passionate, very excited about it. Like you and I are excited about OT things.
OT nerdiness.
Exactly. So it's not a large community, and there aren't a lot of people with the specialty certification either. So it's one of those things when you do become aware of it, when you do start to look for it, you just see that it's so prevalent. It becomes like, it kind of smacks you in the face a little bit. Like, wow, this is so prevalent, and it's an area where OTs can make such a difference. Yeah,
definitely. So let's get can you give a little bit of background on like the different types of vision, or just some like areas that you look at during an assessment?
Sure. I'll kind of, just to kind of give a little bit of an education thing.
Yes.
Some of the 3 kind of most common low vision diagnoses that you might get a referral for, or even that you just might see. You might not get a referral for it per se, because a lot of us are generalists, not focusing on low vision. Mm-hmm. But one of them is called diabetic retinopathy. Just a brief little education about that. It's, obviously caused from diabetes. It affects the blood vessels that support the retina, and it can cause any level of vision loss, including total blindness. So when you see someone with diabetic retinopathy, kind of the symptoms that you're looking for, they sort of have the spotty areas of vision loss. These are called scotomas, the fancy word for it, but they're just spotty areas of vision loss. A lot of times the clients that I see with diabetic retinopathy is they have fluctuations in their vision. So some days might be better than others. Even some moments they might experience a blurriness in their vision, and then other days it might be better. They have poor contrast sensitivity. So being able to distinguish, monochromatic environments aren't very good for them. Color discrimination, as well as they're very susceptible to glare. So, glare sensitivity is big for them as well. They also might start to see things in kind of a rosy tinted color. And that's just caused from like the hemorrhaging of the blood vessels. So that's a big common diagnosis. Another one is glaucoma. A lot of us know what that is. And it's just essentially like a really unhealthy pressure buildup inside of the eye. And this causes damage to the optic nerve. So people with glaucoma, it's kind of called the silent thief in the night because usually they don't experience the symptoms until it's in a very advanced stage. But if you can get someone, if you can make sure that your clients are doing their regular eye exams, this is something that can be managed before it becomes too advanced. It's a very manageable disease. But it can also cause complete blindness. People with glaucoma mostly lose their peripheral vision first. That's what sort of goes first, but then it can get their central vision later on. The most common low vision, the thing that you would see in a low vision clinic as an OT is age-related macular degeneration. AMD is the acronym for that. But it primarily affects your central vision. It's kind of it's caused from inflammation. But it does not affect your peripheral vision. It won't cause complete blindness. It mostly causes your central vision loss. Mm-hmm. And the fancy word scotoma, there's a central scotoma. So there's there's a blind spot in that central area. And some of the symptoms that you might see would be a blurry or fuzzy vision. People start seeing straight lines as wavy. The fancy word for that is metamorphopsia.
I like a good fancy word.
I know. I'll try to give the fancy words when I can. But essentially all that is just your brain is trying to perceptually complete where the vision, they're not getting that visual feedback. So that's what's causing the lines to be kind of wavy. And then obviously reading and seeing people's faces, that can become, the near vision is what's affected, near vision and central vision.
Mm.
Yep.
Yeah.
So those are the three kind of common diagnoses that we'll see that you want to look out for. If you see that in their history, you want to kind of ask them these questions, or you want to observe, like if you see that someone has a diagnosis of glaucoma, you want to kind of observe them in their environment, see if they're bumping into things. Because again, it's the peripheral vision that usually goes first. You obviously want to see them kind of with someone with macular degeneration. You want to see them, read a paragraph or something. So there's ways of just, even if you don't have those fancy assessments of looking at things and looking at them in their environment and being able to see if maybe there's a vision impairment there.
Mm-hmm. Yeah. Yeah. Well, like I was kind of referencing before, it's like you see it in their chart and they're like, okay, they have macular degeneration. And from my experience, you have like one of two type of people. One people will be like, I can't see anything.
Yes,
and
yes.
You're like, well, you are walking around and getting to where you need to go.
Exactly.
Or
they have the peripheral vision. Yeah.
Yeah, they're just using what they have, but they're like, I can't see anything and I'm blind, and they'll go that whole route. Or they'll have the, I see fine. And then like you said, they're like bumping into things and you're like,
oh yes.
Well. So it's like,
oh yes, it is. I've definitely had that before where a client's like, I'm totally fine. I'm like, okay, read this. And I can't see this.
Yeah. Yeah. Or,
well, are you really totally fine?
Well, and that's why like some of those just like, a screen or an assessment is so important to kind of do, because obviously, as we know with our patients, it doesn't matter what setting you're in. Sometimes what their, perceived ability is very, very different from what they actually can do. So, what kind of, like you were saying, have them read something is kind of a good, quick assessment. What are some other things that someone like a, OT practitioner could, throw in to kind of give it a little screen or an evaluation?
So, one of the things, the great thing about low vision, or I mean, the thing that's most our friend, I guess, is observation. Mm-hmm. If you can go in and observe them in their natural environment, whether that's in a skilled nursing facility or in their home, just kind of going about their daily routine, and just kind of taking notes on what you're seeing. Are they bumping into things? Are they not able to see, when they're picking out clothes, can they not really see the color of what they're picking, or, they're not making sense in what they're picking out? Mm-hmm. Bathroom is a great area because a lot of us, like at my nursing home that I work at now, Everything's this cream color, this ivy color. So monochromatic.
Cream on cream.
Oh my gosh, yes. So the bathroom is a great area. So can they distinguish where the sink bowl ends and the sink ledge begins? Are they kind of, sorry to say this, spitting out their toothpaste like on the sink ledge because they just can't see that barrier? Mm-hmm. Another thing that I do, if they're actually down in the rehab gym, we have a clear glass. Can they fill up the water here? Fill this up with a pitcher. Can they see where that water, in a clear glass, where is it overflowing? Can they not see kind of where the glass ends and that line?
Oh, that's a good one.
Yeah, because that's contrast. Is that tough for them? Like I mentioned before, just having them read a paragraph, also having them copy numbers down. A lot of this, I'll be honest, I'm taking from the BIVABA, which is Mary Warren's assessment, but just having them copy down like telephone numbers or a sentence. Cause writing and seeing it can also give you some, what's going on, as well as, some of the neuro issues. I know obviously inattention isn't a vision issue, but something like that could tease that out as well, whether it's a field cut versus an inattention. There's all these little different kind of tricks as well. Medication management is another big one, being able to like sort their pill box. You can see vision impairment with that as well. Can they read the pill bottle? Yeah. And can they sort their medications? Mm-hmm. So that's another good kind of screen kind of thing that you can do.
That's a good one.
Yeah.
Okay, just like kind of on a side note, it just popped into my head. But like, how do you determine like what's the best color for people to use? Is it like a preference? Is it based upon diagnosis? Is there like research to say like green is the best? Because my thing is like I usually crack all my little tape colors and say like which one can you see the best, and which of course is what you'd want to use. But I mean, is there any kind of rule of thumb?
There's really no rule of thumb with the tapes. Okay. It really genuinely is trial and error with the client. Okay. You definitely want to have a lot of different, like you want to have a bright red, a bright orange, a black, because sometimes black on white is better. So in terms of like the taping, like when you tape stuff, you really just want to ask the client. Yeah. Same, we'll get into this a little later, but same with lighting too. It's really a preference of the client on certain, some people prefer the LED, some people prefer the halogen. Fluorescent lighting is really never good for vision impairment, but it's really just a trial and error. But now when it comes to reading and writing or really reading, black on white or white on black tends to be the best. You want to stay away from the colors when it comes to reading material. Not saying you can never use, a different color, but for the most part, a general rule of thumb is either black on white or white on black. Yeah.
Good one.
Yeah.
Good one.
Yeah.
I like the tips. I'm digging.
I'm going back into my toolbox here.
Yeah. And I'm collecting for mine. I have my Post-it notes. I was telling Cammie earlier, I am a Post-it note woman. So I'm like, Post-it note here, Post-it note there. My husband, I might drive him crazy, but I have my Post-it notes, so I know what I'm doing, and I have my tools of the trade.
Absolutely.
So when do you think, so as a generalist, like I said, we're seeing a patient and we're not seeing them for low vision because I would say in general, most people don't see, a patient for low vision unless it's really impacting their ADLs and the doctor really picks up on it or the patient verbally says that. But when would it be best to refer to a specialist, or what are some community resources to maybe kind of tap into for those types of patients that you're seeing are really struggling?
Absolutely. So one thing that I do want to point out, I just feel that this is so important to mention, is that as occupational therapists, we always have to refer to an optometrist or ophthalmologist. If they're already, if they're being sent obviously from them, that's a different story. But if it's a new impairment or a worsening impairment, we always have to refer back. Mm-hmm. I do just want to point that out because that's super imperative. I know it's not always, I know sometimes what happens is that, they can't be seen, especially in the more rural areas, for maybe even a couple months. So in that case, we can still treat. We just can't diagnose. We can't write anything. We can't say we suspect that it's this. That's not within our scope. So we can do compensatory, strategies like I was referring to earlier, but we do need to make that referral. That has to happen. And I'm so sorry, Mandy, remind me, you wanted some resources out in the community.
Yeah. Is there any organizations or any kind of resources that, that people could, I don't know, like if you talk about like leisure or you're looking for some special type of equipment, adaptive equipment as a OT that they could help, I don't know, provide or support, you know what I mean? There has to be, I'm sure there's resources out there.
Absolutely. So a great place to start is going to be your public library. I live in Washington, D.C., so like I am literally probably in the best place for vision impairment. I mean, there are so many resources here, and I know not everyone has that. And there are a lot more resources, I would say, in the city areas.
Right.
The rural areas, it's a little bit harder, but I would still start with your public library, even in the rural areas. So here, we have our public libraries. A lot of them have, they'll have like an entire computer room, and they'll teach people, they'll have classes for people with vision impairment on how to use certain programs on the computer for like electronic magnification. They have peer support groups. So you want to just start there and see if there's anything. Every public library has a free talking books program. I use it all the time. As occupational therapists, we can actually sign off to say, even if there's not a diagnosis, just to say that our client cannot read, even if they're not completely blind, like at this stage, reading is not really feasible for them. And they can get a free talking books and audio player if that's an option for your client. So that's something that we just print out online. We can sign off for it, and then it'll be sent to our client, and I think they get like 3 or 4 books at a time, and they can send them as they read them or as they listen to them on tape. So that's a great program, and that's any public library. They offer that. The Lions Club is another one, and Columbia Lighthouse for the Blind is amazing. Now, I know they're not in every city per se, but that's a great resource, is to kind of look up them online. Columbia Lighthouse for the Blind here, it's actually located in Silver Spring, Maryland, where I am. They have a great low vision store. So sometimes I'll send my clients there with, their family member or caregiver, and they can buy things like talking clocks and, large print books, large print calendars. I mean, it's just a great resource. And they also have specialists located there. Going back to the specialist question, one of the main kind of specialists that I refer to a lot is the COMS, the Certified Orientation and Mobility Specialist. And, when it becomes out of our scope, we are allowed to do like a sighted guide within, that's within our scope to do like a sighted guide within the nursing home. But when it becomes outdoors, crossing streets, you definitely need to refer to the COMS. They're the ones who would train with the white cane, as well as, teach them the tricks of the trade of being outdoors and being mobile. Yeah. So that's another, and you can Google, COMS in your local area, and I would just reach out to them. A lot of times they'll have their email, maybe their telephone number, and you can reach out to them individually. Yeah.
Yeah. Those are the things that you kind of, in so many different areas of OT, it's like you always want to know what your resources are. I mean, let it be even like traveling if someone can't drive, but like, having low vision options or things. You just need to know what's going on in your own communities, which is so hard, especially if you're moving to a new one. It's like, okay, what's out there? Where can I get my list of resources, not only for you, but also for your patients? So those are great.
Yeah.
Those are really good.
And there are a lot of online, support groups as well. I know, and I'm blanking on the name now, but there's a gentleman who started, for people specifically with macular degeneration.
Oh, okay.
And I am blanking on the name of the website, but that's such a great resource. I know a lot of my clients have found that to be very, very useful. Can do a quick Google search here, because I'm sure if you just Google macular degeneration website, it'll come up.
Support group or something like that. Yeah.
But he has a lot of, I think it might be, is it amt.org? I don't know, but it's there, and it has a lot of resources for people, not just support groups, but just education materials, things like that. So it's great.
Well, people that have experienced it, right? And like sometimes I think that is actually patients sometimes really like to have those resources instead of just a professional telling them X, Y, and Z, like having somebody else out there that is experiencing some of the same things that they have and saying like, okay, this really works. Sometimes they need that little that little extra support and just makes them feel more confident. I feel like they've actually used it. They actually know what's kind of going on.
Absolutely.
So when you're doing like goal setting, do you focus on low vision, or what are some how would you integrate that into goals?
So essentially, I want to give a specific example. A lot of times, even in the skilled nursing facility I work in, people do kind of know me now as like the vision girl.
Ooh, yes.
So I do sometimes get referrals for, vision stuff and, but related to activities of daily living. I do want to point that out. It's, it'll be like a nurse might say to me, oh, they're having trouble, with their toothpaste and they can't get it and I'm just wondering if it's a vision issue, and they used to be able to do this. So that's the referral I would get. So that's very much within our scope. But sometimes I'll get, like, for example, this was actually in home health. I had a woman who was referred for occupational and physical therapy for balance and safety issues. And it was mostly related to getting like in and out of her shower. She had a few falls in her shower. I think it was actually a walk-in shower. And, it's one of those things, if you go in just thinking it's balance and, you're going to miss, in safety awareness, but I saw her kind of walking around and she didn't really seem to have any balance issues to me. So then when I actually observed her getting in and out of the tub, I noticed that she was having a hard time seeing where her grab bar was. It was a kind of a smaller grab bar, and it was kind of the monochromatic environment. It was white on white. And when I looked into her past medical history, she has macular degeneration. So I actually started with the tape. She did better with the black tape. So I put the tape around her grab bar, as well as I put it at the bottom of the shower. And, after a few sessions, she was just so much better with it was definitely more of a vision issue than a balance safety issue.
Did she realize it was a vision issue? Is that something that you asked her?
No, it's so funny. So it's so good that you bring that up. A lot of people, even though they know they have this diagnosis, and even though doctors, I'm not trying to, diss the doctors on this, but
of course not.
It's maybe like 1 or 2 sessions and they explain what's happening, but they're just like, oh, but I can still see, you know what I mean? I can still do certain things. So she did not realize the shower was a vision issue. She genuinely thought it was her balance too. So I sort of teased that out, and as well as the PT too, the physical therapist and I were very much in communication, and she found the same thing. Once I kind of educated the physical therapist on the vision issue, she was able to do more with her as well. So, but no, the patient did not, or the client did not realize it. The client did not realize it. Yeah.
And those are the things I think, like you say, sometimes, like we were talking about earlier, you have a patient that says, I can't see anything, or someone that says, I can do everything. And it's not even about doing everything, but they don't actually sometimes, I think, really fully realize how that impacts their occupational performance. Or like, I know in home health, I remember going into someone's house and being like, oh my gosh, this happens a lot, right? Like this house is filthy.
Yes.
And you're seeing them for other reasons, and you're working on this. And I can think of one in particular that had cataract surgery. And they came back and they're like, I didn't realize my house was so disgusting. But it's because they don't even actually realize how that has impact what they actually can see. So they're like, I can see, I can do what I need to do. But it's like you said, it's like those little fine-tuned things, or how that affects their, ability to step over a tub or grab the grab bar or not grab the grab bar or slip and fall, or, like they don't really see that as maybe the connecting issue.
Absolutely.
Like, so those kinds of things are super interesting. But especially like the cataracts, since they can actually be removed, and they're like, oh my, and she was so embarrassed. and I saw her for something completely different, and
it was clouding her vision.
Yeah. Just didn't actually see it. And you're like, okay. And so it's just looking at the person as obviously what we're supposed to be doing, right? Like looking at them holistically and how the environment and their vision and everything impacts them. But it's like, sometimes I know I miss some of those things. And so you're like,
absolutely. And this is where we as occupational therapists can bridge that gap, because a lot of low vision clinics out there are very, busy, and they don't have the time. The doctor's not going to go into the client's home, and they're not going to necessarily see them in their natural environment. And that's where we are so imperative. And we can be a huge help to a client. So this is where we definitely bridge that gap.
Mm-hmm. Yeah. Do you have any little things that you see most frequently that you find are super helpful, or little, I don't know, tips or interventions or something that you're like, that we may not think about, that you've just, as kind of being on low vision, kind of your focus has been low vision in your specialty. Is there anything that you find that you're like, oh, that's something everyone should kind of maybe look at or try or use, or things that have been helpful?
Yeah, let me try to think about that. I mean, one of the biggest things, obviously I've mentioned this before, the observation thing is key. And just really, again, if you see a vision diagnosis, and even if you don't, just really trying to keep that piece in your mind, like maybe it could be vision, and then trying to do those specific vision kind of tricks I told you about earlier, like the filling of the clear glass with water, seeing how they are in the bathroom, reading, stuff like that. I'm trying to think.
How about with lighting? You were saying that fluorescent lighting isn't necessarily the best. I have had, in my experience, a lot of people don't even like to use lights. They don't turn their lights on enough. And you're always like trying to get people to turn lights on, or but let's put a light in this corner instead, to kind of light this area up. This is an issue. Also, I think it depends on your clientele. Like I've had patients from like low income, or you have someone like from like depression-ish era, and they're like really conservative, right? Like they're like, I don't want to leave my lights on, but they're having, you know what I'm saying? Like there's trying to figure out. So you were saying like fluorescent lighting isn't the best. Is there any kind of lighting is there any lighting that is better than the others, or? Well,
I think what would be more important here, because there's not really a standard with the actual like kind of bulb you're using, or what kind of light that it is. But I have an example for this, because I think it's important. You brought up such a great point, Mandy. I had a client, who I was working with, I think at the skilled nursing facility, in her home, sorry. And, she actually, again, I was there for a different reason, but we sort of figured out she has she does have macular degeneration, and she has it. She was actually reading kind of far, her chair was far away, and she had a shade lamp that was like way up high and had a shade over it, and it was just she was just like, I just can't read anymore, I mean, it's just. So her daughter was extremely involved in her care, which was so great. So I kind of did an internet search with her daughter, and we decided to buy her like a gooseneck lamp. And sometimes those are great because you can adjust, they're adjustable.
Right.
And we ended up moving her chair. We moved that lamp out of the way. We moved her chair in a different position, put the gooseneck lamp on a table kind of, to the side of her. And she was able to read. I mean, that was the issue.
Yeah.
So it's positioning of the lighting is just as important as like the light itself. I would say sometimes more so it's the positioning of the lighting. Those shade lamps aren't always the best. And I know we can't always do that, but another option too that I've used, especially in the nursing, my sniff, is the ones that attach to the books, those reading lamps.
Yeah.
I mean, that can be the difference, that I can't read, now I can. It may not necessarily be that they can't read because their vision is that bad. It might just be the lighting.
Yeah. And I mean, it's not even technically in general an expensive adaptation or a difficult adaptation, but it's actually just doing the adaptation, if that makes sense.
Absolutely.
And making sure it doesn't have, like you talked about before, like the glare or, those types of things. But just because they say they can't read and they have macular degeneration actually doesn't mean that they can't read.
Absolutely.
Do you know what I mean?
Yeah. It may not be that severe where they can't, it's obviously the reading is going to be slowed down a bit, but it doesn't mean that it can't happen. Yes, absolutely.
Yeah. And then they get to participate in those things, those activities that they enjoy. And that's our goal, right? And that's what we want to be doing. And so I think sometimes, I know I just reflecting, all these podcasts always make me think about all those patients. You're like, oh, what if I would have done that? Which we can't help everyone. We can't help everyone.
Of course.
But you think about and say like, okay, yeah, I've had patients that say like, I can't read. And you're like, okay, you just kind of take it, right? Like you're like, okay, I guess if you can't read, you can't read.
Sure.
And you just kind of go on and like, oh, try audiobooks, this and that, which is okay. But like, yeah, maybe it is just a lighting issue, or maybe we need to turn on some more lights, or, the balance, maybe it's not a balance issue, that it's just there's not enough contrast. They're not turning on their lights enough. We don't have enough, distinguishable areas or, that where they can see. It's just like, looking at it from a whole, adding that extra little tool to your toolkit and really paying attention to low vision as how it impacts them and how we can make them safer. So
absolutely. And, I feel like what we as occupational therapists do, we want to find out obviously what occupations are most important to our clients, but then also we want to give them the tools where they can be successful, but it's good to point out that they won't always be receptive to those. But at least you've kind of given them, the tools and maybe gone through a different kind of gone through your toolkit and seeing if something works for them. But again, we definitely need to at least try to give them what can make them successful.
Yeah, absolutely. And it's funny, you kind of say that because I think looking at low vision and looking at those types of things, I think when you look at a problem, a patient has an issue. They can't, they're falling in and out of the shower, as your example was. Uh-huh. And you go in there thinking it's one issue. You think it's a balance issue. Like when we go in thinking it's a balance issue, I think that we're really limiting our activity analysis skills. We're really limiting what we're doing as an OT, and we're kind of doing somewhat disservice is pretty dramatic. That's not really what I mean, but like, yeah, we're looking at it with a very narrow lens.
Yes.
Making sure that I always go back to everything. I don't care if I'm talking with a patient that has a fall or a patient that has dementia or a patient, is actually why is this happening? Like what is the root? We're not trying to just put a Band-Aid on it and fix it. We have to go back to why this is happening and addressing it from the beginning. Sometimes we have to step back and look at the big picture. Is it environmental? Is it vision? Is it balance? You know what I mean? Like what is happening and why? And then we can really look at our patients a little bit more holistically. So
absolutely. Couldn't agree more.
Yeah. That's like an air high five right there.
Yes.
That's funny. Is there anything else that you wanted to add about low vision before we kind of wrap up this little conversation?
So, when we were talking, I was kind of talking a little bit about the low vision box that I created.
Oh, yes.
And I wanted to just go a little bit more into that. Just to kind of give people like, oh, what's in that box? I want to know. So I'll kind of tell you what's in my box.
I'm glad you're doing this because I think people would have emailed me and be like, she was talking about a box that she made, and then I'm like, oh, I didn't even ask her. Okay, yes. I love it. Okay. So low vision box.
And again, this is not the perfect low vision box, but this is just sort of what I have in ours at my SNF that I work at.
And get you going,
Yeah, exactly. So, I have a lot of large print items. Large print will become your best friend in low vision. I have some sample large print checks. And just so you know, your clients can order large print checks through their bank. So I have samples that clients can kind of practice on. I have sample large print pill bottles. So, I think I got it. It's not an actual, you can get sample large print pill and just print them out and put them on a pill box. So they have those you can print out. So that's a great option. And I've done this several times. You can actually help your client to get large print pill bottles through their pharmacist. They can either call or their family member call, or you can call with them to get the large print. Most pharmacies will do that. I have, it's not in the box, but it's a resource, large print calendars. You can print those out free online, and those have been really helpful for my clients. I do have the different colored tapes, of course, for the sink ledge, maybe inside the bathtub, grab bars, stuff like that, on the edge of a door as well. And then I also have kind of the different small reading lights that you can either attach or like one that you can kind of shine like while you're reading. So I just got those at the dollar store and Target and I have bump dots. I don't know. They're amazing. If you're in low vision, you know exactly what these are. They're just literally what they sound like. It's kind of a tactile option for someone who can't really see. There's also another tactile option called High Marks. And that's just like a brightly colored gel. And when it dries, it kind of dries, it kind of protrudes up. So like, for example, I've used this on people's microwaves a lot. So like I'll maybe put an S on the start button so they just can kind of feel, for someone with like macular degeneration where they can't see the buttons, maybe put
Is that kind of like old school puff paint?
Exactly. It's exactly like puff paint.
Does it come in fluorescent colors?
It is. And it does. It comes in different colors. But really, you're kind of giving it, yes, you're giving it a bright color, but you're also giving it a tactile.
Yeah.
Yeah. And you can do this with like medication bottles. Like if they have, this doesn't always work out, but if like all of their medications have start with a different letter, like, putting the different letter on top of the pill bottle so they can just kind of feel it. So it's a really great option too. And then I also have signature cards in there. Those are great too. You can probably print these out or make them on your own, but essentially they're just, I got mine from I did like a training at Hopkins, the low vision clinic at Hopkins Medical in Baltimore. And they just gave me a ton of these signature cards. And essentially they're usually black. They have a little open cutout so that the client can sign their name. It gives them a little tactile feedback as well as that vision feedback, because usually when you're signing on a white or cream paper. So it does the contrast as well. So that's a great little option. And then I have like the large print books as well, a few large print books. So that's sort of what's in my toolbox. And I wanted to mention one assessment that is great for home health and for SNF and even in a hospital setting too. But it's called the Self-Report Assessment of Functional Visual Performance. The acronym for that is the SRAFVP. This was created by the one and only Mary Warren, who, if you can't tell, she's my go-to. We have her to thank for a lot for OTB even being involved in low vision. But essentially this self-report consists of two parts. The first part is a 38-item self-report questionnaire. And that can be completed by the client or their caregiver. And the second part is a 7-item observational assessment, but that's optional, where you actually observe them doing certain tasks. But the questions are ordered from most visually demanding to the least.
Okay.
And the client either labels each item as they're unable to do it, it's difficult for them, or they're independent with it. And what's great about that is generating goals, because the things that they're completely unable to do and the things that they're independent with, you're not going to really create goals around those. But the items that are difficult, you start to kind of see a pattern when you actually start to score it. You can base your goals off those difficult items, which is what I love about this assessment. And the other thing that's great about this assessment is you can actually generate a G code, which is phenomenal for SNFs and outpatient. We all know. So I love this assessment, and you can print that out online. I'm pretty sure the score sheet, I think you can get it for free, but don't quote me on that. But I was able to get it through because I took her program.
Yeah.
But it's great.
I will check that out. If anybody's ever listened to some of these past episodes, I shouldn't say get on my high horse. That sounds really, but I get really passionate about like using those objective measures in how it feels like a lot of work on the front end. But I feel like if you're a person that struggles with goal setting, if you have those objective measures, they translate right into your goals. Like that was a prime example. You see like, okay, they're having problem in this. Okay, I can write a goal based upon that. And so like, yes, sometimes it is a lot more work on the front end, but in addition to like just the demands of, our payment systems and people wanting us to have objective measures, and they're helpful for our patients, but also like it makes goal setting so much easier.
Absolutely.
So I just encourage people.
You make a great point. I mean, I know I'm talking a lot about observation, but we have to have the objective measures. You are absolutely right, Mandy. We have to have them for reimbursement and for justifying what we're doing. So that's a great one. Another one that I love for brain injury. So you're looking at your strokes, your TBIs, things like that. Is the BIVABA. And that's the brain injury visual assessment battery for adults, also created by Mary Warren. There's a patent.
Go on, Mary Warren. Giving her a shout out today.
I know, and I know there's other people that have done a lot for low vision NOT or for vision impairment. So I don't want to discredit them, but I just my go-to lady. But this is also very easy to use, and she talks a lot, and with this assessment, I'll just kind of briefly touch on this, but the visual hierarchy. So you have these foundational vision skills being your ocular motor, your visual fields, and your visual acuity, and then you kind of move up on the hierarchy. So sometimes as occupational therapists, especially, I hate to say this, but sometimes I notice this in peds a lot. We automatically want to say it's a scanning issue or it's a visual perceptual issue, but it really might actually be a lower level issue, because if the lower level is affected, it's going to affect everything above it. So, sometimes I've even done that where I've said, this is a scanning issue, but really, no, wait, it might be very slight, but there is an ocular motor issue, which is a lower level skill. It's one of the foundational skills. And what I love about this assessment is she kind of takes you through that. She teaches you how to assess each of the skills, and you want to start with the lower level skills and work your way up the hierarchy until you figure out where exactly the impairment is. And it comes with a video where you can see how to do each of the tests. And then she has a nice binder that's included as well, that not only teaches you like how to score and gives you the scoring forms and how to do the assessments, but also if you're seeing this is what you might also see in occupational performance. If you're seeing this as an impairment. So I just really love this assessment as well, but it is, you can buy it on her Visibility's website. I swear I don't have stock in the company, so I don't really care if you buy it or not, but, it's, I think, like $400 or $500. So that might be something worth, especially if you're seeing a lot of neuro clients, asking your directors to get. It's a great exam.
Oh, and I love those resources, and especially when you have somebody that's actually used them and likes them.
Yes.
And can recommend them and be like, yes, this really worked, or this is super helpful, or you know what I mean? Like you have that.
She just literally spells everything out for you. And it is, once you start to use it, can be very intimidating because it comes with a bunch of different assessments. But once you start to use it, I mean, it just becomes such a go-to. It's great.
Yeah. Oh, cool. Very, very cool. Holy moly. Lots and big old low vision education bomb today.
I'm so sorry if I overeducated. Oh, I love this.
No.
I love vision impairment, low vision.
I love the OT passion. Well, and that's what the podcast is about, honestly, is like getting people excited about OT. We get burnt out, right? And it's really fun to have conversations with people that are excited about what they're doing. And then you're like, oh, I can use that in my practice. And it's just to raise up the profession and do the best that we can for our patients. So
absolutely.
Thank you.
Absolutely.
It's super excited. But I wanted to tell everybody a little story how I met Cammie. Well, Cammie she is a little OT-preneur, if anybody knows. There's a few of us that use this term. We're like OT-preneurs, but, just trying to like get out there and, in the OT world and sell things and produce things that are helpful and get content out and support each other. But, she is the creator of Clinitotes.
Yes.
Will you tell everybody a little bit about that? So this is how I found her. We connected, this social media connections. But tell everybody about Clinitote because it's awesome and kind of want everyone to hear about it as well.
Yeah. So I'll give a little brief story because I know obviously time-wise too. Essentially, about 3 years ago, I was, working in the skilled nursing facility, and it was a large facility. And I was just finding myself, I was using one of the grocery tote bags and just stuffing all my tools in there. And I do a lot of room treatments there. I treat in the gym too, but I do a lot of room treatments. So I was finding that I was forgetting things. So I'd have to go all the way down to the gym on the first floor. And this was a 5-story facility. So it just wasn't working for me. So I said, I want to find a medical bag for myself. The ones that were out there just weren't that attractive. I didn't think they were that great of quality. So then I was like, well, let me get a bag that's maybe not a medical bag, but something that looks nice. The Timbuktu, the Michael Kors, Longchamps. And they just didn't have the pockets that I needed. So I decided, well, maybe this is something I can create myself. Kind of a nicer, higher end, organized bag for clinicians. And I sent out some surveys to my colleagues. I got about 200 responses, and I designed a messenger style and a tote style bag based on these surveys. Kind of what pockets are you looking for? What material do you like? Each bag comes with 2 over-the-door hooks. So for anybody that's in home health or even working in a hospital setting like in med surg where you're going from room to room, it's great because you don't have to set your bag on you shouldn't be setting your bag on the floor. I should rephrase that. But, you don't have to find a spot and lay down your paper towel. You can hang it over the door or some drawers and chairs.
That's my favorite part of it.
Yeah.
Or one of them. Yeah.
It's a really great option for the home health people. They just clip onto the back. And, it is a little bit, I know I've heard this is so expensive, but the quality of the bag is really what I focused on. The nylon is a really high-end nylon. It's not going to tear apart within, a couple months to a year. It's going to last you 10, 15, maybe hopefully 20 years. I mean, it's a really good quality bag. So, and I wanted it to look nice. I didn't want it to be like a typical medical bag. So, and it fits all my tools. So it's great.
Well, it has all those little pockets. Like you have your computer pocket and you have little pockets you can put like TheraBand and your goniometer and your, oximeter. And it has all these little individual things instead of like piling it into this one big old, I don't know, maybe it kind of looks like probably my purse does. Like You're just like digging in the bottom,
yes,
trying to find your lip gloss. But you know what I mean? Like it has all the little pockets for all the little things that we use and need. And that it's just awesome. But yeah, so actually, Cammie, I have a promo code. So if anybody wants to check them out, it's Clinitote, CLINITOTE. Is that right?
You got it right.
.com. And if you use promo code Seniors Flourish 10, you get $10 off your bag. But yeah, we met through social media. And so that's one of the reasons why I love social media. I get to meet so many cool OTs.
Absolutely.
No. Isn't it fun? It's so fun.
I'm such a fan of yours, so I got to meet a celebrity OT through Clinitote.
Oh my gosh, that makes me blush. Makes me blush. Too funny. But anyway, thank you, Cammie, so much for being here, and thanks for talking and sharing all your tips about low vision.
Uh-huh.
And great talking with you today.
Yes, thank you so much for having me, Mandy. I really enjoyed it.
Yeah. Thanks, everyone. Until next time.
Hi, guys. Don't forget to check out the live courses from my sponsor, Great Seminars and Books. I love the variety of courses they offer, specifically because they are relevant to the populations that we are working with every day, older adults. And their topics include things such as home health, a specialty course of its own, and clinical implications of pharmacology for the therapist working with the older adult. So all these topics are relevant, evidence-based, and very practical. These are treatments that you can learn in the course and take back and use right away. So head on over to seniorrehabproject.com/great and use my promo code SRP25 so you can get $25 off your next live course.
This podcast is brought to you in partnership with the Senior Rehab Project at seniorrehabproject.com.